Hello, and thank you for joining me today. My work prior to COVID-19 focused on HIV and overcoming challenges to the engagement of patients in prevention, care, and treatment, including research to better understand medical mistrust as a determinant of suboptimal uptake of biomedical HIV prevention strategies. Today, I'm going to talk about combating COVID-19 vaccine misinformation, disinformation, and mistrust from my own clinical and research perspective. I have no disclosures. I will start by defining misinformation, disinformation, and mistrust and describing their origins, then turn to their impact within the COVID-19 pandemic with a specific focus on COVID-19 vaccines. Then I would like to offer some suggestions that in my clinical experience and in the experience of others might be useful. Let's start with some definitions. Misinformation is what it sounds like. It's false or incorrect information that is not intentionally meant to mislead anyone. Conversely, disinformation is strategically and deliberately spread false information, which is created to mislead. The difference, in general, is the intent of the information. Both have spread rapidly during the COVID-19 pandemic, secondary to the widespread use of social media. Understanding the origins of misinformation, disinformation, as well as mistrust, which I'll turn to next, is critical to developing messaging and appropriate responses. The spread of misinformation may arise from the need to understand a new phenomenon where an evidence-based understanding has not already been established, like during the current pandemic with a new virus. The spread of misinformation and disinformation in the setting of an emergency also evolved from a need that we all often have to cope with anxiety and fear when faced with unknowns. Interestingly, sometimes quote-unquote conspiracy theories are viewed as a form of disinformation, but oftentimes they're not intended to mislead, but to provide explanation where there is none. The spread of misinformation and disinformation occurs more frequently when there's inadequate, inconsistent, or non-evidence-based responses from leadership in the setting of crisis, and can be very powerful as a component of an adverse political agenda. Racism and xenophobia may also lead to disinformation, as we have noted during the pandemic, unfortunately. For example, in regards to the origins of SARS-CoV-2. Lastly, anti-vaccination movements have existed throughout the world for centuries. The most notable example relates to measles, mumps, and rubella vaccination, and its now debunked link to autism. Whether the origins of anti-vax movements are philosophical, political, or spiritual, they have promoted both misinformation and disinformation to support their cause. What about mistrust? Mistrust is the absence of trust that providers, organizations, researchers, or others genuinely care for patients' interests, are honest and transparent. Mistrust is rooted in the lack of trustworthiness of institutions and systems. Mistrust promotes the spread of misinformation and disinformation, and vice versa. Mistrust and misinformation may be able to be addressed, and I'm going to offer some strategies during this talk. Disinformation, because it oftentimes derives from sources that are deliberately established to spread false information, is actually very challenging to combat. Though mistrust intersects with and may promote the spread of misinformation and disinformation, we need to understand that its origins are distinct. Medical and research mistrust are well documented, particularly among Black individuals in the United States, but also within other populations globally. The reason that medical mistrust is so prevalent among the Black population in the United States is because of historical and contemporary structural racism. Black individuals, as well as Latinx and Indigenous populations, have limited access to healthcare, more illness, worse outcomes, and experience more premature deaths than their white counterparts in the United States. These disparities have existed for many years. Mistrust is believed to be a rational and normal response to persistent adverse circumstances and a result of ongoing trauma and marginalization. Mistrust is certainly not solely a U.S.-based phenomenon. Denial of HIV as the cause of AIDS and efforts to refute the efficacy of antiretroviral therapy or HIV treatment may partially be based in mistrust of science originating in the Western world. These beliefs intersect with and overlap with quote-unquote HIV conspiracy theories. Denialist beliefs gained sustained momentum in the HIV epidemic in sub-Saharan Africa, specifically in South Africa, but other countries too, not only because of charismatic leadership promoting these beliefs, but also because people were marginalized, had limited access to resources, and were vulnerable. Similar denialist beliefs and conspiracy theories regarding HIV have been noted in the United States and in other countries, particularly within communities of color. These beliefs are still quite prominent. In 2002, one of my colleagues conducted a nationally representative survey of Black individuals living in the United States, and they found a very high prevalence of HIV-related mistrust. That's another term for HIV conspiracy theories. We repeat this survey more than 10 years later, and these beliefs are still prevalent. For example, half of all respondents at both time points believe that HIV is a man-made virus, and half at both time points also believe that there is a cure for HIV and that the government is withholding it from the poor. Turning back to COVID-19 vaccines, what types of misinformation and disinformation beliefs are common? There are groups dedicated to quantifying the frequency of myths related to COVID-19. Here are the top 5 reported by one source. These are in order of frequency. Number 1, mRNA from the vaccines can alter human DNA. Number 2, vaccines contain microchip surveillance devices. Number 3, COVID-19 vaccines cause infertility. Number 4, the vaccines developed by Oxford University will turn people into monkeys. And number 5, COVID-19 vaccines contain aborted human fetal tissue. All of these beliefs are described as myths. Some are clearly misinformation, but all 5 have been strategically disseminated by groups and individuals with the intent to mislead online. These beliefs may impact willingness to take the COVID-19 vaccines. These are data from a survey conducted by a polling company and published by Reuters of 19,000 individuals across 16 countries. Of note, none of the countries are in Africa. Unfortunately, I do not have detailed methodology in regards to the survey. However, we can look at this as a snapshot of what may be happening in these individual countries. These data suggest that the country with the largest population of individuals who would be unwilling to be vaccinated for COVID-19 is France, where there's a long and extensive history of vaccine skepticism and anti-vax sentiment. Turning to the U.S., willingness to take the COVID-19 vaccines has fluctuated over time as a response or a reflection of the political context and as new data have arisen regarding the vaccines within the last year. Overall, according to data collected after the November election in the U.S., approximately 60% of individuals were willing to take the COVID-19 vaccines. Black individuals reported the lowest willingness at 42%. In addition to misinformation, disinformation, and mistrust, there are also other issues to consider in regards to vaccine hesitancy, which, as defined, has 3 components. Value is whether or not someone believes that they are at risk of infection. Access, affordability, and availability also contribute to willingness to take a vaccine. And of course, as already described, trust in the effectiveness, safety, reliability, and competence of the healthcare system and the motivations of policymakers are critical determinants of vaccine hesitancy. In this survey conducted by the COVID collaboration, fewer than half of all Black and 66% of Latinx respondents were willing to take a COVID-19 vaccine. Trust in vaccine safety and efficacy were the 2 most important predictors of hesitancy and were extremely low amongst Black individuals, but also relatively low amongst Latinx respondents. There is good news here, though. The majority of respondents were basically taking a wait-and-see approach, essentially meaning that if all goes well, they will most likely eventually be vaccinated. From the data collected by my research team, not only do mistrust and disinformation impact vaccine uptake, they are also associated with less adherence to preventative measures such as social distancing and mask wearing, and lower acceptability of COVID-19 treatment. What do we do about this? Most effective interventions to address vaccine hesitancy employ multiple strategies to address misinformation and mistrust, as you see in this figure. In the short term, providing people with clear, transparent messages that include what we do know and what we don't know about the vaccines is important. The use of trusted messengers is critical. Longer term, particularly as it relates to marginalized communities, systems and institutional change are required to address mistrust. A considerable amount of the work to address vaccine hesitancy has involved mobilizing healthcare providers as trusted messengers. According to numerous studies, healthcare providers are the most trusted source of information regarding COVID-19 vaccination. But I strongly believe that engaging peers, faith leaders, community health leadership, and other respected individuals is also important, particularly if they themselves have already been vaccinated. Engaging communities who have been marginalized in the actual process of vaccine development, whether that be decision-making, in the research, not just as clinical trial participants, but at the initiation of studies to determine the overall approach, and message formation and in message delivery is also a proven strategy to combat misinformation and promote trust. But this type of engagement will involve investment in communities that have been disenfranchised and marginalized to build capacity for community members to engage as equal partners in these efforts. In terms of disinformation, as I mentioned, it is difficult to combat. But you can report misinformation and disinformation online and therefore help stop it from spreading. In the context of a strategic partnership with the UK, the WHO has joined forces with its communications teams to raise awareness of misinformation and disinformation around COVID-19 and encourage individuals to report false or misleading content online. Here's a snapshot of links provided to report misinformation and disinformation noted in social media, and you can find these by going to the website noted at the bottom of the slide. As COVID-19 vaccines become more widely available, healthcare providers and others will be called upon to engage patients in discussions around uptake or willingness to be vaccinated. Here are some communication strategies that might be effective. In general, responding to questions, misinformation, and mistrust regarding the vaccines in an understanding manner with an empathetic tone is important to engage patients in open dialogue. Validating that mistrust and skepticism are normal is also a useful strategy. Being non-judgmental and non-confrontational, asking open-ended questions, using reflection or reflective listening skills is also appropriate. Overall, the idea is to promote conversation and open dialogue with patients. Motivational interviewing techniques provide helpful strategies. The development of open communication demonstrates that you care about patients holistically and you hear their concerns. Reflect and roll with resistance, or in other words, leaving room for patients to state their concerns in their own words and reflect their concerns back to them, and reflecting their concerns back to them is also a strategy. Don't immediately correct misinformation or disinformation. Listen first, ask questions, then provide accurate information and allow patients to make their own decisions. Lastly, a number of potential messaging themes and strategies have been suggested that should, of course, be adapted depending on the population or community or patients who you're speaking with. As mentioned, acknowledging that mistrust and skepticism and fear are normal, particularly during a pandemic involving a new virus, is a strategy that could be used. Transparency regarding the known effects of vaccination, clear communication regarding the risks and the unknowns, the role of social responsibility in vaccination, the responsibility of family and friends, reframing vaccination as a form of self-empowerment, and emphasizing choice are all messages that can be adapted depending upon the audience. In conclusion, misinformation, disinformation, and mistrust are heightened during emergencies such as the current pandemic. They have a significant impact on willingness to take the COVID-19 vaccines, and understanding their origins is useful to determine appropriate interventions. And finally, adopting an understanding, non-judgmental approach is an appropriate communication strategy to combat these ongoing concerns. I hope that this was helpful. Thank you.